Welcome to Team Gut Girls, the podcast for anyone who's ever unbuttoned their jeans at 10 a.m., mapped out every public washroom in a 10-kilometer radius, or wondered why one bite of food can ruin an entire day. We talk about bloating, constipation, diarrhea, reflux, nausea, abdominal pain, histamine chaos, and all the quiet gut symptoms you're told to just live with. Join naturopathic doctors Dr. Whitney Baxter, Dr. Christina Carew, and Dr. Dominque Vanier. Your gut is talking, and we're here to help you translate. You're with Team Gut Girls now. Let's dig in.
And before we dive in, just a quick note. This podcast is for educational and informational purposes only. It's not meant for medical advice and doesn't replace working with your own healthcare provider. We're sharing general information, not diagnosing or treating anyone. Please always talk with your physician or licensed healthcare practitioner prior to making changes to your health, medications, or supplements.
So today I wanted to talk about what if bloating doesn't actually come from your gut. Because I have patients that come in and they talk about having this heavy, swollen feeling, and they feel like they have pressure, and sometimes they have constipation. And they say nothing is working. And we've tried everything, but it actually could be a circulation issue. And so today I wanted to talk about something that is massively underdiagnosed in women. And I would say even I missed it many times, pelvic venous congestion. And ironically, I had a patient that came in last week that I hadn't seen for 7 years. And she told me that everything that I've been doing was really good for 7 years. And then she got really constipated. And she said, I had this massive hemorrhoid. And then I started taking Vinexia, hemorrhoid supplement from flavonoids. And she's like, it started to improve things. And that got better. And I was like, wait a second. And I started asking her a bunch of questions, which we'll come talk about today. And I actually think that she actually has a pelvic venous disorder, which is one of the reasons why she was getting this chronic constipation on top of all the other things that she has going on. And so I thought that this was a really valuable topic, especially because I think it's reasonably new that we're starting to get more information about it. And even in the location where I am, there's one person that we can refer to that knows what we're talking about. And so I think that's pretty helpful. Maybe we'll start with what are pelvic venous disorders and a little bit of what you might see in your own life, or if you're a practitioner listening, what you might see in your patient's life, and then we can have some discussion. They're the second leading cause of pelvic pain that exists for longer than 6 months of endometriosis. And I would say very commonly people with endometriosis also have pelvic venous disorder. So think of it in either or, think of it as it often happens in pregnant women or women 5 to 40. It's the only time, and sometimes they've had it for much longer and just hasn't been spotted. And certainly people without pregnancy can also have this. And it's actually also in males. So if a male patient was having all this, he had irritation in his penis and it was like always red, and he was always having all this redness. It was an infection. And we kept trying all these other things. And then one day he was talking about how he had varicocele in one of his testicles. Well, wait, and we're like, wait a second, maybe this is it. So we've actually sent him to get checked. So it looks a little bit different in males, but we'll primarily talk about females. It's primarily the person who most likely has it. And often these patients are told that they have IBS and something just doesn't add up. So they've done all the gut stuff, they've done all the things, and it isn't really helping. And so it's not really a gut problem. Okay, so what is pelvic venous congestion? So it's a broad category, and it talks basically about varicose veins that are in the pelvis. Instead of the blood moving back up to the heart and creating a sort of circulatory system, it pulls and creates pressure in the abdominal region and stretches the veins. So when we think about things that are similar, when people with endometriosis, lots of leg pain or lots of leg swelling, we think about endometriosis, we think thyroid problems. This should be on your DEX list or your consideration list. And so it's basically like a traffic jam in the pelvis. So all the blood goes in, but it doesn't come back out. And so people start feeling heavy or swollen or pressurized, which can feel like bloating, right? It's the most common thing that we're going to say. I feel like I'm bloated all the time. And this wouldn't really have much to do with any kind of eating or foods in particular, just be like, oh, it just doesn't feel good. And so it's actually pressure buildup that sort of mimics gut symptoms because it's literally in the same place. And so I'll give you an example. I have a patient that has Crohn's disease, history of Crohn's disease for 20 years, and she has long COVID. And the doctor that I co-treat her with was like, oh, there's all these studies done and long COVID. It's definitely what this woman has. And so we did a stool microbiome test, and it was amazing. It's like the best one I've ever seen. And it doesn't look like you have Crohn's even on this stool microbiome test. And at the same time, we sent her for some imaging around the pelvis, and sure enough, she had seen like on the examination, like collapsed veins. So basically like everything is building up in pressure. And so the interventional radiologist, who's the person who typically starts the process in this, opened up one set of the veins for and arteries for blood flow, and suddenly the bloating changed completely. And so it was really interesting because it was like we assumed because she had Crohn's and she had long COVID that was like this one category, and it was completely different. So even practitioners that are aware of it can still make some question. So what kinds of things do you guys want to know?
Listen, I think this is a really important topic because it is not on the radar of a lot of practitioners, right? When patients come to you with all of these non-specific, we'll call them gut symptoms, but it's actually an extra intestinal driver here. The treatment plans are often trying to treat the gut when, like you said, that's not it. That's like secondary to something else going on, or at least presents in that region, but that's not it. So I guess one of my questions is, like, Christina, I think you've seen these cases a lot, possibly more than, we have, given like your clinic setup, et cetera. If somebody has like done a lot of their own digestive homework, like cut out certain foods, tried supplements, are they coming to you saying, I didn't respond to any of it?
Yeah, I would say mostly people come in and they say, I have bloating, or I have pain, or I have pelvic pain. And so what I started doing was like questioning sort of around pelvic pain. Is it all the time? Does it spread to your low back, to your hips, to your groin, like your thigh? Is it low body pain? It's sort of like starting the endometriosis screen. Is it worse end of day? So we see that in some of the conditions we've already talked about. Is it worse with sitting or standing? So anything where things are like accumulating, right? Moving. Certainly menstruation, ovulation, pregnancy, and sex all affected because it's a lot of activity in that same pelvic region. So that can be like a one where people say, oh, I have a lot of painful sex. Again, we still automatically start thinking about things like endo, but this is also still similar and can also be comorbid. Generally, people will say feel better when lying down. So I see this a lot. We see it a lot in POTS patients. So our patients have orthostatic intolerance, so their bodies are like having dysregulation of their blood pressure. Some of it actually can be as a cause of this, and some of it actually be alleviated by treating POTS. So it becomes this kick and sometimes other things people will say, it feels like I have urinary urgency without infection, well, that pooling and pressure in the area. Or have pain when my bladder is full. I have to go to the bathroom often at night. It feels tight or swollen or pressurized in the abdomen. What they perceive as like bloating, constipation actually can result from this because more pressure in the system, right? No different than symptoms we would see with women who are pregnant. So more pressure in the bowels, more varicose veins, things like that. Same kind of idea. It's just carrying water instead of child. Lots of pelvic discomfort with bowel movement. So you can see there's like a lot of interlinks between other things that we would start on our consideration list. I would say not everyone, but some of them will say veins showing in my butt. I have hemorrhoids. I have inner thigh saying I have swelling in my legs. I feel better with compression. And a big one is also fatigue, because they're always in pain. They're always discomfort. So they often will even come in with fatigue. And then it sort of starts this, starting to go through this system. And so there's a lot of, go ahead.
I have a question. Is it because sometimes in pregnancy, women will have more varicose veins and some will even need surgery? So are you seeing that connection too?
Yeah. So it's like that vein stretching, the change in hormones, they seem to maybe be part of what's contributing to this, either hyperflexibility of the veins, collagen issues, it can be just flow issues, it can be changes due to all kinds of different reasons. And so I don't think it's like, oh, because this, but I would say pregnancy definitely can make it worse for sure. Or maybe also recognized, right? Because now it's like a clear reason that there is both maybe more pelvic pressure and also more baby on board pressure. I would say there's lots of kind of comorbid things. So, beyond pelvic pain, think about patients or people that have migraines, brain fog, mood changes, muscle pain, fatigue, certainly GI issues. And then we also think about it in patients that have fibromyalgia or ME/CFS, any kind of fatigue issues, that PONS kind of patient, the hypermobile patient. So there's the endo patient. I have a patient that has endo and has pelvic venous congestion. Part of the problem is the treatment for this is actually creating more space. So actually doing stents. And so they're worried that the reason the collapse of the structure is because of the endo. Like the endo is actually creating. So then they're like, oh, well, we need to get the endo treated first to make sure that like the treatment will help, but the endo kind of treatment. So this treatment, because I don't know, a lot of people diagnosed, at least in our area, seem to be pretty quick. People are getting it in weeks, months, or years, which is amazing until people start like extend. But the endo treatments are like years and years, right? And so people have this one piece of the condition, which is very much solvable, but they can't get the other piece solved to like A has to happen before.
Yeah. Yeah. And just a reminder, like endometriosis, you can have endometriosis tissue grow far from the uterus. There's cases where it's found like in the lung region. And so even though endometriosis is thought to be like a female pelvic region condition, it's not actually. It's kind of like a system-wide issue.
Yeah, it's a structural issue, right? Because blood has gone through the fallopian tubes, expanded into the body cavity, and then it adheres.
Yeah.
And so I do have a patient that has it in their lungs. It's super hard to get even someone to investigate it. So you're not crazy. Some of these things exist, but they're super rare. And so they're not always on the radar. So there's there's this general area called pelvic congestion syndrome or pelvic venous insufficiency or pelvic vein disorder. And so it's like the veins are compromised, leading to blood pooling. So people feel worse with intercourse, worse on standing, worse with menstruation, heaviness, varicose veins in the vulva or in the legs, painful sex, fatigue, and bowel urinary issues. So that's like general. Once someone is investigated, they actually can find it's often left-sided. So left renal vein compression or left iliac vein compression. Often people will say, I have more swelling on my left side. That's actually can be a hint. It's always the left side, but it can be. Blood in the urine. I actually had a patient, I was thinking of this when I was preparing this podcast, was like, oh, I have this patient who has blood in her urine, unknown why it is. We sent her a kidney specialist, we sent her for a cystoscopy, and I was like, maybe it's this. I actually wrote myself a note to call her and be like, hey, do you have any of these other things? Orthostatic intolerance can be part of that. So one is called Nutcracker syndrome and one is called May-Thorner syndrome. So it's like which side is compressed. And in May-Thorner, it's the left internal iliac vein is compressed, but then it overlays the right common iliac artery. So you have left-sided sort of interaction. Sometimes people will say they can tell by feeling people's abdomens and feeling fluid or feeling things around the ovaries. I think it's like, it's not super clear. It's one of those things where you're just like, oh, this is the diagnoses where you're like, okay, you have all of these things. Let's make sure that part of what's.
I have a question about like the lower leg swelling, or if you do see some of this congestion, is it like, because like when there's swelling, we're looking to see, like for listeners, if there's pitting or if it's just generalized or when it's happening. So we're trying to assess what the swelling, the characteristics around the swelling to help us figure out what could be causing it. So what would this look like?
It honestly depends on the person and how much compression they get. So some people will start the day and have to change their pants by the end of the day because there's that much swelling. It also depends on the amount of fluid that you have, are you near your menstrual cycle? So there are things that definitely can worsen it. And so it depends. Lots of people, they'll send pictures, and I don't know if you get this, but I have this picture that people send pictures of their abdomen to show me the thing. And so sometimes they'll be like, oh, it's so full there, and it goes down my legs, and I feel. And so even asking, do you get those little lines on your legs when you wear socks? That can tell us. It may be really extreme for some people, and it might just be like what someone assumes is a normal amount of fluid movement in the day.
I would expect it to like ebb and flow too, right? So, there may be patterns or there may not be. But so far, it seems like there's some sort of peripheral fluid accumulation, fluid overload type picture, plus digestive symptoms, possibly distension too. You're seeing bloating, but are we actually seeing an increase in girth in the abdomen? Okay.
Yeah. Because it's fluid, right? Yeah. And so, and then also if people wear compression, so some of these patients also have diagnoses like orthostatic tachycardia. And so one of the treatments is way more compression, trying to keep the fluid up, but then it creates more pelvic congestion. So more bloating because it's not going all the way back up to the heart. It's just going up from wherever the stocking socks pants are. Yeah. It's crazy. So I would say one of the things that often happens is motility gets slower, because remember, this is a blood flow issue, right? And so when we're thinking about blood flow and motility and nervous system and our breathing patterns, so all of our diaphragm, this is something we'll talk about in another episode, all those things become other side effects. And so it's easy to get distracted away from it because you're like, oh, I know what that is. I know what nervous system is. I know what motility is. But I think we just don't think enough. I actually was like, every time I think about it or I talk to someone, I'm like, oh, there's this person now that this is probably like, the more you think about it and once you see it a few times, you're like, there's so many other patients that maybe this is of what was going on. Especially if you treated everything to do with your gut and you've tried all these different things and it hasn't really resolved anything. I would say it's certainly high on the list of things to be like, oh, is this actually a piece? And especially if you're getting some of those urinary urgency, painful sex, hemorrhoids, varicose veins, low back pain. It might be, or you've chased down endometriosis, been told you have lesions or lesions that are detected. This might be another place.
Or even for those going through perimenopause, menopause, if it's not, because there's the urinary and changes that can occur with like painful sex or irritation, more UTIs. So if you've tried some vaginal estrogen, and I guess that wouldn't really solve it, wouldn't fully answer it, and your urinary analyses are all normal. This is something else to consider too.
Or people that feel pressure but not like gas or breathing or anything where they're getting a heaviness. I would say for me, I always like this place between constipation and not constipation, right? Is the constipation the thing that's causing the pelvic pressure, or is the pelvic pressure causing the constipation? And so I think it's like this sort of back and forth piece when we think about people that are passing things in a way that feels like the body is able to do it very easily.
So if you think about the pelvic congestion issue leading to digestive issues, if we back up before the whole pelvic issue started, if we're thinking about some other risk factors, pregnancy is definitely a big one that we've gone over. I would assume like age is also one. We're more likely to have this as we
People
age.
that are hypermobile.
Yeah.
So hypermobile, an end of the spectrum is Ehlers-Danlos, but people can have more flexibility and not have Ehlers-Danlos or be somewhere on this like spectrum. So think about like swimmers, gymnasts, figure skaters, anyone that yoga teachers, anyone that has more flexibility, because that also means that the structure of their body is more bendy. And so in bending, we see that. We think that part of this, that the vein system has really been impacted by COVID and COVID vaccinations, partially because ACE inhibitors are in all of these structures. And so I think that's the reason why we're seeing more of it now. It's just, well, a lot of people maybe were on the edge, or like it's more common. Certainly people with blood pressure dysregulation issues, anyone that's had like a long-standing illness. So whether that's lung disease or mold toxicity, anything which like kind of stalled the mitochondria, stalled the system. I think it's more common than we would think. And I think some people are probably born with this. Like I think we probably all people, even that we went to high school with, who would be home the days that they had their period because they would be in so much pain or agony. How much of that was maybe undiagnosed endometriosis and how much of that is maybe sort of like some blood flow issues that are also contributing to that pain.
Mm-hmm. So is that like an ischemic pain then? Like it's just, or I guess just like pressure, not ischemia, but.
Well, so like, some of my patients will say they like double over in pain lying on the floor of the bed. Like that sort of really intense pain. Some people will say a dual ache that they can kind of ignore. And so it depends on, I think the thinner the patient is, the more pain they have because it's like more pressure and more pulling. But it also depends if like they also have another hormonal condition overlies that.
Mm-hmm.
So they have pain from endometriosis and they have pain from having more pelvic pressure. It's either or situation. It can be a both.
So with like would Advil help this pain, do you think, or no?
I'm sorry, people who are like, to take Advil and just feel it.
I've tried all these things and nothing worked.
I would say people come in and they'll be like, I was given gabapentin for my pain, right?
Yeah.
Or I was given these really strong medications, or I was given like strong migraine medication, but it's not working.
Mm-hmm.
Start thinking about it in the people where things aren't working.
Yeah.
Like, I don't necessarily think that we're going to catch it as a primary diagnosis just because there are all so many like check boxes. But when people aren't better, or the things that you're doing that should be helping aren't getting better, and we can start looking at it and being like, oh, wait a second, like, is this a piece that maybe is getting missed?
But when you're investigating this, because certainly like it's not in our scope to do some of these diagnostic tests in Ontario or in BC, where Whitney's located.
Yeah.
You're referring to, so you're commenting. So the medical doctor is referring to which specialist and what tests are used to diagnose.
So what we have been doing, if we suspect, we are referring to interventional radiology. And so patients can ask their practitioners, even medical doctors, they can go with symptoms and say, hey, here's kind of what's going to be happening. I would say most of the traditional medical system has no idea. It's just not on their radar yet. And there are actually in the Toronto area, there's a number of studies going on with a few doctors from a few different hospitals working together. So they are trying to actually like contract all these patients together to get a better understanding of like how it presents, how they're addressing, which is great. So generally what happens is patients may have like a pelvic ultrasound. That ultrasound doesn't necessarily give like a ton of information. They'll generally go for like a pelvic MRI and to be the next step. And usually that's referred to by the radiologist, or if they've already had a pelvic MRI, they can look at it and say, okay, you need some more information. And it's usually a venography. So it's like actually patterning the veins to see where there's compression. And then if they are a straightforward case, then stenting often becomes an option for them. In my patient that has endo, they actually did an injection to try to create a mimic of a stent to see what kind of symptoms would it alleviate for her if they were able to open the passageway. And so that in her, it only lasted like 2 or 3 days. So it wasn't super long before it became compressed again. But she said some people last 2 weeks. And so they were trying to see if there is something endo that's compressing everything. You know, is this actually help with some of her pain, or are they following down the wrong rabbit hole? Is this something also happening, but maybe the contributor to the pain that she's having? And so that's sort of where it is. So from like a naturopathic doctor standpoint, our role really is helping people to even consider it on their radar, helping people to present information to their medical doctor or nurse practitioner so we can refer them into the system, trying to figure out if there are interventional radiologists in the area who have more of that interest in this. Even in the US, there's a ton of people. There's a couple of clinics who are really, really good at it and have a lot of patients that they treat. But I think this is a new area that is probably been around for a long time, but maybe more newly kind of recognized. And so I think we will see more of this information coming faster, especially with the internet. But I think it's just the radar right now.
Mm-hmm. Definitely not. Yeah. And certainly what makes it tricky is there are so many systems in the body where we can have symptoms overlapping, like endometriosis we've talked about, POTS, digestive issues, possibly circulatory issues, but that doesn't seem like that's the conversation that first starts with the patient. They're coming to us for different reasons. Yeah.
Yeah. Right. And I would say often the patient will come in because of constipation.
Yeah.
They'll come in because of constipation or like bloating. And then it's only as you ask more questions and do it. And so I started in my practice kind of just being like, okay, it could be this, or it could be one of these 3 things. Let's kind of investigate as much as we can simultaneously so that we can make sure we get an answer to you as quickly as possible.
Mm-hmm.
Yeah. So certainly, I mean, we're learning more every day, but I think from a bloating perspective, maybe not a common reason people think that they have bloating, but gosh, I had 4 in the last week in clinic. I was like, oh no, I think this is actually it.
Wow.
Yeah, I'm sure you are too. I'm thinking like a few.
Yeah, there's a few people. There's actually a few people, and it may have been that I missed it, or, one of them is like, I've got constipation, digestive issues, and my legs and my arms also feel pumpy. There's a fluid aspect. We talked about a peripheral fluid aspect to this. Yeah. And again, it may be related, it may not be, but there definitely needs to be some level of investigation that happens there. And as naturopathic doctors, one of the main benefits that we can bring to the table is our investigative hat, because we have so much time with people. We're asking about different systems, not just like a 5-minute appointment. Oh, you're constipated? Let's try this laxative and then come back in a few months, right?
Yeah. Yeah, exactly. Yeah. Pulling it all together.
Yeah.
And then it's peace of mind too, to say to somebody, hey, all the things, like, you're not failing your treatment. You're not this mystery. There's a possible explanation for all of these, what feels like random symptoms, that when something is off in your body, like, people say that, right? Like, no one's thought about this, or I don't think it's IBS, but that's what people keep telling me. There's something else going on. It's nice to have this conversation with people.
Well, and things can manifest as IBS, right? Like IBS can be primary, but it can also be secondary. And that's really important for people to know, because IBS, yes, is a true condition. It is not a catch-all condition where, oh, we don't know what's going on, so you have IBS. There are people that are definitely diagnosed with IBS, but IBS also, some people I have had where they've actually had celiac disease and they've been told that they have IBS for years, right? And so when we talk about root cause medicine, where we're able to actually find the root cause, that's really important that we do end up doing that.
And really, it's like a few additional questions, like thinking just about that pooling, gravitational piece, any kind of vein hemorrhoid. Some of the questions that we ask, but maybe don't give as much weight to. And also just looking at your patient, right? Like they probably have come in, unless they're the first person of the day, they've been sitting or standing. Some of that is possible. You could even just be like, oh, do you have any of this? So as a patient, is this starting to resonate with you, where you also are wanting to learn more? I would say certainly ask your nurse practitioner, doctor, I've been having this pressure and bloating. It doesn't seem to be related to my food. It gets worse around my cycle. It might be not gut related anymore. I've heard about pelvic venous congestion and how it can mimic gut symptoms. Is this something we can consider out? Can you help me to investigate this, or can you send me to a specialist that can help me look into this further? So not to be completely surprised if your practitioner has never heard about it before. It's commonly on the radar. It used to be pretty rare. It's now maybe not as rare, or maybe it was never rare. We just didn't notice it. But certainly can be a thing to ask about. And if people don't know, send them to our podcast and then can tell them to read it. We'll give them some more information or resources. And we'll link some, there's a couple of good other podcasts that I listen to on this topic, and we'll link them in the show notes just so that you can hear some voices talking about it as well. So, key mindset shift, which is what Whitney said. You're not failing treatment. You've maybe just been given the wrong framework, the wrong diagnosis. It's not just IBS. Sometimes it's maybe something else in the pelvic region that we need to consider. And certainly we have some coming episodes about other things in the pelvic region, hormonal conditions, and red flag concerns that we have that we also can see as having more external pelvic symptoms that aren't gut related. But certainly having kind of congestion in the pelvic region can also mean that we get more gut symptoms because we're just putting more pressure, more signaling issues in one area. And so I would say certainly a lot of these conditions overlap. Fortunately, there's just one problem. Someone has a problem generally, unless they've come to you very early on in their concerns. And so as gut health practitioners, it's part of responsibility is to look at all parts of the being, not just the gut. Certainly the gut is definitely affected. So everyone, buckle up. We still have more episodes left on reasons for bloating, much as everyone can't imagine. I think we have more than 20 ideas of why you might be having chronic bloating. And so if we haven't hit it yet, it's coming up. Stay tuned because better gut health changes everything. Thank you for joining Team Gut Girls. Like, follow, subscribe, and share a podcast with friends you think will want to know more about their gut. You can also visit us at teamgutgirls.com for show transcripts and more information because better gut health changes everything. See you next time.